Thank you for inviting me to come and speak to you all today. If you can't hear me at all, please let me know. I think we're just checking out that the hearing loop is working as well. Okay. So as you can see from the slide, I'm an intensive care specialist by training, and I first got involved in this about 12 years ago when I was concerned about the number of patients who were coming into the intensive care unit and receiving treatment that they probably didn't want. I remember one particular case of a man who had cancer, who wasn't going to recover. He ended up in our intensive care unit with pneumonia, on a breathing machine, on a ventilator, and his wife and daughter came to me and they had tears in their eyes and said, "Why are you doing this? If someone had only bothered to ask, we could have told you that Dad didn't want this." And he ended up dying in the intensive care unit on the machine, unable to communicate with the family and unable to say goodbye or express any wishes. And it was at that point that I realised that we needed to be doing a better job about giving patients the opportunity to say what they would and would not want. And I think this particular slide, once I turn the machine on, really brings it home to us all. This is a picture of an elderly man who came into the emergency department from a nursing home by ambulance with severe dementia. He was no longer able to recognise anyone or anything, was completely incommunicado. He was bedbound, doubly incontinent, and really was just eking out an existence in the nursing home rather than living. And he came in with pneumonia, and as you can see, he's got some tubing to his nose and nasal prongs delivering oxygen to his breathing. And we had two choices here. The emergency department doctor could start off by taking blood cultures, putting in a drip, starting antibiotics, taking him up to the ward, and then if he deteriorated, taking him to the intensive care unit and putting him on a ventilator and putting him through all that, having him recover well enough to go back to the ward and then slowly recover on the ward to then go back to the nursing home to continue to be severely demented, unable to communicate, bedbound, doubly incontinent. Or the doctors could sit down with the family and talk to them about what they believe their father would want. They could talk about allowing nature to take its course or allow a natural death, or talk about the fact we used to refer to pneumonia as the old man's best friend. In other words, they could spend the time sitting down and having to talk to the family about what would be in this man's best interests, rather than just going through the motions of getting him onto the health conveyor belt and delivering to him a whole lot of things that he may or may not want. Here's another situation. Here's an elderly woman who's had a cardiac arrest, and there's the ambulance officer about to shock her heart, and there over in the corner is the other ambulance officer speaking to the emergency department about the ECG and working out what to do. But the person I'm particularly interested in there is the husband. He's there looking down on his wife. His whole married life is flashing before him, and he's thinking, what's going on? And he's wondering whether she's going to recover back to how she was before. He's wondering if she's going to survive. And he's wondering, is this what she would want? And so I think these two cases are illustrations about the fact that as doctors and nurses, we need to be doing a better job of talking to our patients and finding out what they really want at a time when they've lost the ability to communicate. Now, often I find that people say to me, well, you know, you're a doctor, don't you have to do everything? Don't you have to sign that Hippocratic oath that says do everything no matter what? And, well, for those of you who aren't aware, as doctors we don't have to sign any Hippocratic oath. We don't have to stand there with our left hand on our heart and Scout's honour and I hereby declare that I'll do this, that and the other. But in fact I became more interested in this Hippocratic oath and I decided to try and look at the source documents. Now, I don't know about you, but I had trouble with this particular source document. So I had to look at something that's more recent. And this said that essentially I'll prescribe regimens for the good of my patients according to my ability and my judgment, and I'll never do harm to anyone. In other words, beneficence, which means, I'll do good, and non-maleficence, I won't do harm. And I'm sure you've heard people talk about doctors say first do no harm. And these things, of course, apply just as much to nurses and other health professionals, not just doctors. So a more legalistic way to look at this is to see what's our common law duty of care as doctors. And again, this applies just as much to nurses. And it is to take reasonable steps, which means as other reasonable doctors would do. And what that essentially means is if someone decided to take me to court as a doctor, my best defence is to line up next to me other doctors who would attest to the fact that what I was doing was reasonable. And it says here to take reasonable steps to save or prolong life or to act in the patient's best interests. So if you think back to that first slide of the fellow lying there on the trolley, sure, I could put him through all those different things. I could save his life through the machines, but would I be acting in his best interests? And the best way to identify best interests is to find out what the patient wants. And that's what advanced care planning is. So here's a quote. Here's a definition. It's a process whereby a patient, in consultation with healthcare providers, family members and important others, makes decisions about his or her future healthcare should he or she become incapable of participating in medical treatment decisions. And this is a quote from Peter Singer, not the philosopher that we know, but a Canadian geriatrician. And the ethical principles that underscore this are those of autonomy, particularly around informed consent. As doctors, we shouldn't ever do anything to you without having fully informed you about what it is and got your consent to proceed. And secondly, it's about dignity, about the prevention of suffering. So here's a case study to just bring home to you how this really works. This patient, Mr. A.G., was 81 years old. He was living with his wife. He'd been diagnosed with lung fibrosis, which is a type of scarring on the lungs, and he was being treated with steroids and oxygen, but he wasn't responding because with this particular condition, it's very uncommon to get a response that lasts any period of time. When he was first introduced to our program at the Austin Hospital, Respecting Patient Choices, he said, so that was in July 2004, he declined to talk about it because he said, I'm going to get better. I don't want to talk about any of this death and dying stuff. But he had subsequently several admissions. And so when we reapproached him in January 2005, he said, well, I've actually been thinking about this and I can tell you a few things that I do and don't want. I don't want one of those tubes down my throat, and I don't want to end up in intensive care or receive other aggressive management. So what did he do? Well, he discussed his wishes with his GP, and these were documented on a discussion card, but he didn't end up getting round to appointing his wife as his medical enduring power of attorney, and he didn't end up completing one of our forms, our advanced care directives, called a statement of choices. But he subsequently became acutely breathless at home, and he asked his wife to call the GP rather than the ambulance, which is what he would have done in the past before he'd had time to reflect upon these things. And his GP attended him and provided comfort care at home, and he died surrounded by family and friends. So what this case illustrates is that advanced care planning doesn't have to be a legal thing. We don't have to focus about just filling out the forms. Indeed, in this man, he didn't fill out any forms. He simply had time to reflect upon what's important to him, his goals and values at that time, how his illness or his health was impacting on his condition, and then he was able to talk about it with his GP and his wife, and in the end, he got what he wanted, and he didn't get what he didn't want. The second point that's illustrated in this case, it's not about the legalities. There was no one standing there saying, well, if you haven't filled out a form, we're going to do everything. It's really about ensuring that we knew what he wanted. Now, for a number of years, we have had a lot of evidence supporting advanced care planning, but we were still struggling to get the attention of doctors and other health professionals. And some of the people were saying, well, where's the magic randomised control trial to prove that this really works? So in the end, we bit the bullet. We conducted a randomised control trial, and this ended up being published in 2010 in the British Medical Journal, and it's ended up being one of the major articles around the world on this particular topic. And as you can see from the title, the work was to look at the impact of advanced care planning on end-of-life care in elderly patients. And it was a randomised controlled trial to ensure that there was certainty about the findings, because we weren't able to adjust or control the way the study was conducted based on our own biases or prejudices. And so we took about 300 patients, and they were randomised, these people over the age of 80, when they came into hospital, to either receive normal care or they received normal care plus advanced care planning delivered by one of our trained nurses. And there are a number of things that we found. Most importantly, we found that there was an improvement in the care that the patients received at the end of life. And when this nurse went and spoke to the patient, he or she would then identify what was important to this person at this time. He or she would also ask the patient, if you got so sick that we couldn't talk to you and we had to make decisions, who would you want us to speak to? Now, by answering that question, essentially what that person was then telling us was who was their preferred substitute decision maker. And then once they told us, and they usually told us a family member to be that person, we then asked them if they wanted to fill out a form to make that legal. So here in WA, that form would be the enduring power of guardianship. So that then there was no question for the doctors and nurses as to who would be the right person to speak to. And then the next question they would ask would be, that's good, we know that. Now, what if we couldn't get hold of that person? Can you give us a bit of a sense of what would be important to you? And I often quote the example of saying to someone, what if you had a stroke and you ended up being very sick and we could see you're going to end up in a nursing home, being fed by a tube? Would life still be good enough for you if you could be pushed outside in a wheelchair and feel the warmth of the sun upon your back? And of course, if the patient said that's fine, then that's good, at least then we knew. But we'd also say, but maybe your bottom line would be that you'd want to be able to recognise family, to talk, to be able to feed yourself, to be able to look after yourself, to be able to wipe your own bottom, to be able to do the normal things that you're doing now. And what we generally found was that people said to us, if I get any worse than I currently am, I don't want any ongoing treatment. It doesn't mean I want you to stop now, but if in the future I become very unwell, I want you to keep me comfortable. I don't want you to impose upon me treatments that will end up leaving me unable to walk or talk or look after myself. And then we would also talk to them about any other particular requests that they would have. So that's really what an advanced care planning discussion is, and it takes somewhere between 20 minutes and an hour. And it's most important that in having that discussion that the health professional having it spends time listening. Because as doctors, we spend far too much time talking to the patients and not enough time listening to the patients. So what did we find apart from the fact that the care at the end of life was much better in the group that got advanced care planning? We also found that the level of satisfaction that the patients felt and the family felt about the care that was delivered during that admission was much higher in the group that had the advanced care planning. It's probably simply because someone bothered to come along and talk to them and particularly listen to them and find out what was important to them. The gilding of the lily on this particular study was the fact that we followed what happened to the family members of people who died. And we found that in the family members whose patients had had advanced care planning, there was a statistically significantly lower incidence of anxiety, depression, and post-traumatic stress symptoms in the family members when we assess them 3 months after the death of their loved one. And I'll tell you why in a moment. So what are the sort of things that the patients were telling us? Well, here was feedback from the patients who didn't get advanced care planning. They mainly made negative comments like, the doctors don't listen. I felt ignored and in the way. They don't want me as I'm too old. They wouldn't speak to me and kept discussing things with my family. Now, we only know those things because we asked, because we were conducting a study. There would be elderly people over the age of 80 in every hospital in Australia right now having those same thoughts. That's why we as a society and we as health professionals need to do a better job on how we're caring for and communicating with patients, particularly elderly patients, patients near the end of life, patients who are struggling to be able to communicate to us about what they would and would not want. What did the families think? Well, here are some of the things that the families said when their patients, their loved ones, had been through advanced care planning. That's what we call the intervention group. They said things like, he had a very peaceful death, just as it should have been, and I'd like to thank the staff for this. And even though we'd already knew what he wanted, it was great to be able to talk about it so openly. Whereas in the control group, the patients who didn't get advanced care planning, their family members said things like, Mum didn't want heroics. I was horrified to hear she received 45 minutes of CPR. She didn't want it. All anyone had to do was ask. And the doctors kept asking if Dad should be resuscitated. I didn't think they should keep asking, as they also told us it wouldn't help him. It was obvious to us he was dying. I mean, it's very embarrassing to read those sort of things happening to patients in our hospital. And it just shows what a big difference it made when we bothered to train staff to be able to go and talk to patients about what they would and wouldn't want near the end of life. And not only to the patients, but always to involve the family in the discussion. So this study showed that advanced care planning improves end-of-life care and patient satisfaction. It also showed that it empowered the patients now, not just in the future. It was amazing how often when we started talking to patients about this, they'd say, you mean I can have a say about what's going on now? And it was always just amazing to find out that patients didn't realise it's not up to the doctors. Of course, it's up to the doctors to do a good job. It's up to the doctors to advise them. It's up to the doctors to act in the patient's best interest, but it's not up to the doctors to make all the decisions. And it's also not up to the families. It's actually up to the patient to tell us what they want after we've given them the opportunity. The third point there is that advanced care planning assists the family because it helps them to know the patient's wishes and to be involved in the advanced care planning discussion. And because of that, then they're more able to make decisions when the doctor comes to them when their loved one's very sick to say, what do you think we should do? And so the family moved from being in a position of saying, oh my God, I don't know, we've never talked about it, what should we decide? And feeling burdened by it, to saying, I absolutely know what Mum wanted. We talked about it. And I want to play my role in advocating for Mum and making sure she gets the care she wants at the end of life. And so because of that, they're less stressed, less anxious, and less depressed because they're more satisfied with the quality of the care they saw their mum get at the end of life, not only because it was better care, but because they played an active role in ensuring that was delivered. So I'd like to just touch on some other points. Advanced care planning does work with people with dementia. Just because someone may not be able to tell us who the Prime Minister is, or may not know what date and month it is, doesn't mean that we can't ask them about what they would want if they got sick again. And it doesn't mean they can't say to us, oh, if I get very sick, I don't want to go to hospital. I want to stay here in the nursing home, or I want to stay at home with my family. Or they'll say things like, I've had a good innings. Or they'll say things like, you know, it's been good up till now, but I don't want it if it gets any worse. And even with patients who have got severe dementia, who may not be able to tell us a lot, it doesn't mean we can't go and speak to their families and help them to focus on not what they want as a family, but what the patient wants, because that's the important bit. The second point to point out, to bring to your attention, is that this is not euthanasia. Euthanasia is when you deliberately take someone's life by, for example, an injection. In intensive care, if you have a very sick patient who's not going to survive and you take away the machine, they're dying not because you took away the machine, they're dying because they had a very severe underlying illness. And here, advanced care planning, it's about finding out what people want at the end of life. Now, sometimes people with advanced cancer, they go and see their oncologist, and their oncologist talks to them about surgery or chemotherapy or radiotherapy. And the patient may say, oh, look, I had a friend who died from stomach cancer. They had a miserable time. I don't want to do any of that. I want to go on a trip to Alaska in the time that I've got remaining. Now, of course, there are many patients who decide what they do and don't want, and we, of course, respect it. We can't tie the patient to the chair and say, well, sorry, we're going to impose this treatment upon you. So if the patient has a choice over that, why wouldn't they have a choice at other times? When we've done advanced care planning, we've had many times when the patients called us back and said, look, I didn't tell you when we first started talking about this, but I was actually thinking about euthanasia because I was so scared about losing control at the end. But you've now reassured me that you've listened to me, you've helped me write all this down, so that then when it gets closer to the end and I don't have the same ability to make decisions, I'll feel like I've still got control over what's happening. And now that's lifted such a weight off my shoulders, and now I can continue to concentrate on living as well as possible, and I'm not interested in that euthanasia stuff anymore. So it's more about withholding future treatment as per the patient's wishes rather than about withdrawing treatment now. And I also like to inform you that we've done a lot of work with Catholic Health Australia, and the things that we follow with this do align with the Catholic Code of Ethics, where they talk about treatments being overly burdensome or where the treatment burdens outweigh the benefits. So I'd like to just bring to your attention that there is a lot of legislation around Australia that supports advanced care planning and better end-of-life care. The only state that doesn't still have any legislation to support this is New South Wales. But I'd like to point out two common law cases that help to inform what's going on in this area. The first one is titled, It's the Patient's Choice. There's a nursing home here in WA called the Brightwater Care Group. And they had a patient there called Mr. Rossiter, and this is all out in the public domain. I'm not telling you anything that's not been in the newspapers. Mr. Rossiter was a quadriplegic, so he's paralysed from the neck down. He had a tracheostomy to help with his breathing, and he was receiving artificial nutrition and hydration, which is abbreviated up there to ANH, through a peg tube, one of those plastic tubes put into the stomach through the skin. And he said, I've reached a point where I don't want this anymore, and I'd like to make a decision about being able to stop my feeding so I can die. And the Brightwater group were concerned that if they did this, they might get charged with murder. So their lawyers recommended that they go to the Supreme Court to ask for what's called a Supreme Court declaration. And the Supreme Court agreed to hear the case and to make a decision on this. And here are two quotes that I think are very relevant to this. They said, a patient who is capable of making informed decisions after weighing up the alternatives has the right to do so. And secondly, having informed the patient, which is the legal duty of the doctors to explain the benefits and the risks of the decision they're making, the doctors should comply with his request and would not be criminally responsible. So this really answered the question that the nursing home had as to what would happen if they did stop the feeding at the man's request and he died. not only did it reassure the man that he has a right to make this decision, it also reassured the doctors and nurses that they wouldn't get charged with murder if they complied with his wishes to stop feeding. The next case to tell you about, another Supreme Court case, occurred in Newcastle in New South Wales, at the hospital there called the Hunter New England Area Health Service. And they also had a patient called Mr. A, who had previously completed an Advanced Care Directive, which is abbreviated to ACD there. He refused life-sustaining treatment. Now, he subsequently became very sick and was admitted, unconscious, and put onto dialysis as an emergency. Then the staff discovered his Advanced Care Directive, which refused dialysis. So they thought, well, we could stop his dialysis, but if we do, he's going to die. Are we going to get charged with murder? So they did the same as in the Rossiter case. They went to the Supreme Court of New South Wales and asked for a declaration. And the New South Wales court agreed, and these are the quotes they made. They said, if the Advanced Care Directive is made by a capable adult and is clear and unambiguous and extends to the situation at hand, then it must be respected. Secondly, it would be battery, which is a legal term for assault and battery, so assaulting a patient. It would be battery to administer medical treatment to a person of the kind prohibited in a valid Advanced Care Directive. Thirdly, a refusal of treatment did not need to be an informed refusal, i.e. based on medical information. In other words, it's valid whether it's based on religious, social or moral grounds, or even upon no apparent rational grounds. So really what the court was saying there is that a patient, in other words, a human being, can make any decision they wish to make, and they don't have to justify it to anyone, just like any of you. I mean, you could choose not to have life insurance or a house insurance or car insurance. No one can tell you you've got to do that. That's your choice completely. And as much as the doctor might want to tell the patients the risks of this and the benefits of that, the patient doesn't have to listen. That patient I described earlier who's told that they've got stomach cancer, the doctor might start to tell them about all the different treatments. And at that point, the patient may politely cut them off and say, look, I already know I don't want any treatment. I don't need to hear about all your medical information. I've already made my mind up. And that's absolutely their right to do so. And it's not up to us as doctors and nurses to second guess whether the patient's making the right decision. And the last point there was the court said, even in an emergency, you cannot treat contrary to a known Advanced Care Directive. So if a patient comes into the hospital and they're acutely unwell, the doctors can't decide to go ahead just because it's an emergency if they're aware that an Advanced Care Directive already exists to prohibit that. Now, I'm just going to briefly tell you about the advanced care planning we've been doing in aged care facilities. This work I'm about to present is the work we've done in Victoria a number of years ago, but we're now being funded by the federal government to introduce advanced care planning and better palliative care into aged care homes, 3,000 aged care homes across Australia, and to also work with general practitioners to improve the understanding and the skills around advanced care planning and end-of-life care. So in this particular work, we conducted a study where we delivered advanced care planning to potentially to nearly 1,100 over 1,100 residents. And the first point to bring to your attention was that of all those discussions, there were more than 500 discussions, only 2% of these elderly people refused to have further discussion. And I think that's really important because it helps to answer those critics who say, you shouldn't be talking about this stuff to older people. You'll remove all hope. You'll make them depressed. They'll feel like there's nothing left. But in fact, these people want to hear about this sort of stuff. They want to know what their options are. They want to be able to have a say about what's going to be done in the future. Secondly, 16% of these residents died during this 2-year project. And of these, 58% of the people who died had been introduced to advanced care planning. And of these, 89% had filled out some sort of advanced care plan to say what they wanted or didn't want at the end of life. And the sort of things they said were, I don't want to go to hospital if I get sick. Or they said, I just want to be kept comfortable. Now, they didn't use the term palliative care, but essentially they were saying they wanted to be kept comfortable. They didn't want to have any extraordinary treatments. But a lot of the other amazing things they said were deeply personal to them. They'd say things like, I'd like a penny in each hand for the ferryman. Like, please call my priest. And they'd write down the name of the priest and the telephone number. Or they'd say things like, I'd like irises in the vase when I'm near the end, please. Or please leave the curtains open so I don't feel claustrophobic. Or can you play certain music? We had one person who said, can you please play the Essendon Grand Final on my TV? Which was lovely. And it was fantastic to see how committed the nursing staff were to this. You know, there was a nurse who knew she was going to be off for 2 days, so she pinned a note to the Mabel's curtain saying, remember to leave Mabel's curtains open because she'll feel claustrophobic. And the feedback from the nursing staff, they wrote things down in the evaluation. Things like, I feel proud to be a nurse again. Because up until then, the nurses weren't allowed to have these discussions with the patients because it was left up to the doctor. And the doctors weren't having the discussion, so the discussion didn't occur. And so the patients weren't getting what they would want at the end of life. And so in this study, we can see that 96 to 100% of their wishes were respected at the end of life. I mean, how good is that? If that was a drug trial, that would be headline news on all papers across the world the next day. We also found that if patients didn't get advanced care planning, they were much more likely to be transferred to hospital by ambulance to die in the emergency department or up on the ward, being cared for by staff that didn't know them from a bar of soap. So by comparison, those people who did get advanced care planning, you can see that 18%, only 1 in 5 ended up being transferred to hospital, compared to nearly 50% of the people who hadn't had a discussion, simply because someone had been trained to sit down and talk to them about what would they want near the end of life, put it in writing, talk to their families, so that in the middle of the night when things went wrong, they didn't just call the locum and then automatically call the ambulance. They thought, let's deliver the kind of care that this elderly person wants at the end of life here in the nursing home, being cared for by staff that have come to know and love that person. And as I said, there was much greater satisfaction from not only the residents and the family, but also the staff and the GPs about this whole process. So here's an example of how it worked. This 96-year-old woman, she was competent, which is a medical term for she had her wits about her, but she had quite advanced Parkinson's. She did an advanced care plan saying what she did and didn't want, and then about 5 months later she deteriorated. It was a general deterioration. She also had a urinary tract infection, a bladder infection, and she was put onto oral antibiotics by her GP. And she was reviewed by a GP and her family, particularly her daughter, who they decided to keep her comfortable. But she deteriorated further on the weekend. And so the staff called the locum. And there was the locum, and the locum said, send her to hospital, because he wasn't going to come and see her. So this was a reflex action. But fortunately, the nurse who made the phone call had been trained by us and understood all this. And she said, well, Doc, look, I really don't think that's what she would want. How about we talk to her daughter? And he sort of said grumpily, yeah, okay. Hung up. And so the nurse did speak to the daughter, and the daughter said, look, please just keep Mum comfortable, keep her in the nursing home, but still keep going with those oral antibiotics, because I was told by the doctor that helps to control the symptoms of the cystitis, which it does. And so they were continued, and she died peacefully in the nursing home the next day, surrounded by family and friends. Now, as a doctor, I can tell you that if this 96-year-old woman who with progressive infection had been transferred to hospital, she would have still died. But here she died comfortably in the way she wanted. we're just coming near the end, and these particular next two slides are to show you that it's all about the language we use. So here was a particular study where they looked at the three words. So instead of using the three words, do not resuscitate, they used the three words, allow a natural death. And they wanted to see what impact this would have on the endorsement of the way they spoke to the patients, the endorsement of the nursing staff. And what they found is that the endorsement and therefore the use of these words and the engagement with the patients was significantly higher in the group that were using allow natural death compared to do not resuscitate, which sounds like such a negative, prohibitive thing, rather than let's allow natural death. You can see what a difference the language we use makes in the way we communicate with patients. So what I thought I'd use the remaining time to do is to take you through the Western Australian document of the Advanced Care Directive. It's called an Advanced Health Directive, and it's available to anyone in Western Australia. I was home. I'm originally from Perth. I live in Melbourne. I came home recently in September for my mum's birthday. And she's in a nursing home. And she's absolutely bright as a button. She just finished reading David Copperfield in about 2 weeks. Now, I don't know how many of you have read it, but it's about 800 pages. It took me about 3 months, mainly because I was reading it at night and falling asleep, but nevertheless. So we talked about what she'd want, and she told me what was acceptable to her. And so we went through this very document. And so you can see here that you'd fill in your details about who you are, your address, date of birth, and it gives you some other instructions there about this contains decisions. And it says there that a treatment decision in this Advanced Health Directive operates in respect of the treatment to which it applies at any time I'm unable to make reasonable judgments in respect of that treatment. Now, I know that sounds like a bit of legal jargon, but essentially it says, if you can't talk to me, I want you to follow what I've written here. And of course, let me remind you that even if you've done an Advanced Health Directive, if you can still talk, then whatever you say trumps everything, including what you've written down. So, that's on the top of the first page. On the bottom part of the first page, it says these things about treatment as any medical or surgical or dental treatment. And then a treatment decision is a decision to consent or refuse consent to the commencement or continuation of any treatment. Third one, a treatment decision operates only in the circumstances that you specify, and you'll see that in a moment. Fourthly, treatment to which you consent in this Advanced Health Directive can be provided to you, and treatment to which you refuse consent in this Health Directive cannot be provided to you. In other words, it's legally binding. It's not up to the doctors and nurses to choose whether they'll follow your directive. And then lastly, your enduring guardian or another person cannot consent or refuse consent on your behalf of any treatment to which this Advanced Health Directive applies, which means that if you've appointed someone and you've filled one of these out, this trumps the person you've appointed in terms of the decision making. So then, where do we fill it out? Well, on the next page, this is where it says treatment decisions, and it gives you 3 opportunities to fill that out. So it says there, in the following circumstances, and that's where you write something down. It then says, I consent or refuse consent, and then you cross out, and then you write to the following treatment. So, if you're an elderly person in a nursing home, you might write down here, if I have a stroke, or I can no longer communicate with anyone, or I become paralysed, I don't want to go to hospital or receive any treatment. So the point is, don't get flummoxed by any legal jargon. Just remember saying, if A occurs, then I want B, or I don't want B. And it gives you 3 options. So you could fill out here, if I have a stroke, what you do and don't want. Then you can fill out here, If my heart stops, I don't want cardiopulmonary resuscitation. I don't want anyone jumping on my chest. And then the third one might be, if I end up with pneumonia, I just want oral antibiotics, but I don't want to go to hospital. So it's completely up to you. And I think the reason why we talk about asking people about CPR is because it's important they have a good understanding. Most people, most public, probably most of you in this room, think that cardiopulmonary resuscitation is a highly successful procedure because you've watched ER and Chicago Hope. Now, they did a study a few years ago and they showed on ER and Chicago Hope, they got a number of medical students to watch all the episodes to record what was the success rate. And the success rate in the TV shows was 80%. And in fact, most of the people who survived in the 80% group made a full recovery. And in fact, it was even worse than that. Most of them were sitting up having a sandwich before your next ad break. Now, what's the reality? The reality across the board is less than 20%. And if you're in a nursing home, the reality of surviving cardiopulmonary resuscitation for a cardiac arrest is somewhere between 0% and 2%. Now, say if any of you went to see your doctor, say you went to see a surgeon and you had a surgical problem and they said, yep, I can do the operation, but it's got a 2% success rate and 98% failure rate. Now, hands up in the room who would proceed with that operation. Well, of course, none of you are going to put your hand up. You'd be crazy to do so. And yet here we are believing that it's appropriate to offer CPR in nursing homes when the success rate in all comers, where they've looked at thousands of patients, is somewhere between 0% and 2%. So why wouldn't it make sense that as doctors and nurses, we need to talk to patients about this and tell them the reality rather than what they've seen on TV? So moving on to the next page, it makes a few other notes. It says, if you're physically incapable of signing this Advanced Health Directive, you can ask another person to sign for you, and you must be present when the person signs for you. Next, 2 witnesses must be present when you sign this Advanced Health Directive or when another person signs for you. Thirdly, each of the witnesses must be 18 years of age or older and cannot be you or the person signing for you. Fourthly, at least one of the witnesses must be authorised to witness statutory declarations. Now, what that essentially means is you need to make sure that one of the witnesses is a doctor or a pharmacist or a policeman or someone who's normally can sign stat decs on your behalf. And the last point there is that the witnesses must also sign this directive, and both witnesses must be present when each of them signs, and you and the person signing for you must also be present. In other words, you've got to fill it out all together. And that's good because, in fact, when you fill out an advance directive, it's really important to have your family there as well, because not only is then the paperwork filled out, but they've heard what you do and don't want. And if you've got any questions, you can ask them at the time. So if mum says, look, I've got emphysema, I'm on oxygen all the time, I don't want any treatment if I get another exacerbation of my emphysema. And if you think, well, Mum, why would you say that? You're still getting along. And she can then say, well, it takes me an hour to have a shower in the morning. And then I feel exhausted and I just want to go back to bed. And I can't get out to water the roses anymore. And I can't go down to the shops. I can't go to bingo or whatever. So although I'm still pleased to be able to see you and the other family, if I get sick again, I don't want any of that. And that's her prerogative. And then at least then you, as a family, know, so that then when something does happen, not only do you know that mum's filled out a form, but you're across what it's all about. And then this is where you do the signing and the witnessing, and I don't need to dwell on that. And then it's got a last bit there that talks about you're encouraged to seek legal or medical advice. Now, it doesn't mean you need to, but it's worth particularly going and speaking to your doctors so that if you've got any questions about the things you may or may not want, you've covered all that. Look, I won't dwell on all this. You can easily get hold of this form, but don't be driven away from filling out such a form because it seems to have legal jargon in it. The good thing about this form is it is legally binding. So if you've got any question about what you do and don't want, and you're worried that the doctors or nurses may not follow it, then get hold of the form and fill it out. And then this is the last bit about where you indicate whether you've sought legal or medical advice. And then down the bottom, you can tick that box as to whether you've made an enduring guardianship, and you can have that form available as well. In fact, if you do fill out such a form, you should keep the original because it's yours, just like you keep your will. But it's important to make copies to give to your GP, to give to the hospital, to give it to family and friends. Now, some of you might still be doubtful as to whether this is important. So can I ask for a show of hands, who's got house insurance? Now, pretty well everyone's hand went up. Probably those who didn't go up are renting, so they don't need house insurance. Now, I'm sure none of you are hoping or expecting your house is going to get burnt down, but we've all got house insurance. And yet, sometimes people doubt the importance of advanced care directives. And yet, when I last checked the medical research, the mortality rate for human beings is still pretty close to 100%. And so, in fact, this stuff is infinitely more important in terms of its applicability to you and me as it is to house insurance. Now, I walked here from my hotel. Afterwards, I'm going to walk back. I could get knocked down by a car on Wellington Street. Isn't it good that my family know what I would want? You know, if I lost the capacity to walk and talk, I've indicated I don't want to be kept alive as sometimes people talk about it as a vegetable or, in a terribly severe head injury state. So, in fact, this stuff applies to all of us. So I would encourage you to all think about not only talking to your family about this and finding out what your parents want or your partner or your kids or whoever, but fill it out for yourself as well. I'd like to just finish by pointing out that later this month, on the 19th and 20th, we're having our national conference on advanced care planning and end-of-life care in Melbourne. So if any of you want to come over and do a bit of shopping, you can also come to this. So if you look up our website, which is Advanced Care Planning Australia, then you can register. And lastly, if any of you are going to be over in Europe next year in September, you can come to our international conference, which is in Munich. And this conference finishes 2 days before Oktoberfest starts. So you've got no excuse. And on that point, I'd like to thank you for your attention.
Bill has kindly said that he's very happy to take a few questions. Is there anybody that would like to ask a question while we're here? Yeah, we'll just bring a microphone to you very quickly. Look at this.
And can we bring the lights up?
Yes, can we bring the lights up a little bit?
Thank you very much. Thank you for the interesting talk. My question is, if a person was taken to emergency for whatever reason, how would the doctors know that you've got an advanced care document signed?
That's a very good point. The only way they would know that you've filled out one of these forms and it's an emergency is, well, there are several ways. Firstly, and I'm not sure what work has been done with the ambulance service here in WA. I know that work we're doing in Victoria is to make sure that the ambulance service is much more aware of this. And in some states, like in South Australia, have set it up so that if you've got an advanced health directive, you leave it in a plastic sleeve on the fridge. And so that's where people go and look for it. You can also make sure that if you're a regular attender at, say, St Charles Gardner or Charlie's or Royal Perth or Fremantle, that they've got a copy of it so that when you turn up, it's electronically stored on their system. So when they type in your details when you turn up, it immediately comes up with an alert saying that you've got an advanced health directive. And in the long term, what we're working towards, I'm on the National Steering Committee for this, we're working towards having advanced care directives on the PCEHR, the Personally Controlled Electronic Health Record that the federal government are also promoting. But the other important point is to make sure your family are aware, because when you turn up in the ED, the first thing that they're going to do is start looking for your family. And if the family say, oh, look, Mum's already filled out one of these, she doesn't want this sort of stuff, then that helps as well.
Yes, thank you. It was an interesting talk. I was under the impression that there was already a facility to have this information stored electronically. Is that not yet established?
Well, certainly it is, I understand, in hospitals here, but on the current personally controlled electronic health record, all you can do is tick a box that you've got one, and it can record where it's being kept. But for me, that's not much use if what it says is in the bedside table at home, because if you're interstate or if you're in the hospital now, then that's not much help.
And so how do we access that particular facility online? What do we Google?
For the personally controlled electronic health record, if you type that in, if you haven't got a personally controlled electronic health record, you should go onto the Medicare website, and that's where you can find your way through to it, and then getting that. And then you'd need to go and see your GP and tell them that you want to have information loaded up. And you can load that up yourself on the computer and then inform your GP that you've loaded information up.
Thank you. Another question. I know an 89-year-old woman who's been sitting on her blank healthcare director form for probably a couple of years, and the thing that's holding her back is getting the right wording for the different conditions. It's daunting. She doesn't want to miss something out. I mean, what's a good all-encompassing, or what's good to go and look at and use as an example?
Well, there is a website here in WA. The Department of Health has a website for looking that up. What I'd suggest you do is if you Google the words Advanced Health Directive WA, then that immediately brings up all the information that's available. And it also has contact details there so you can get telephone advice as well.
And then back up.
Yeah, happy to keep going.
Thanks for the talk. Can people hear me?
Do you want to just hold it a bit closer?
Louder.
Yeah.
You've been dwelling a lot on end-of-life care and elderly people. What's the youngest age that you can fill one of these out?
You can fill it out as long as you're over the age of 18.
Okay, that's all I wanted to know.
So I think it is important for all of us to do these.
Thank you. There is on Department of Health's website here in WA, you can obtain an alert card to say that you've made out one of those things. Again, like you said, if you haven't got the documents with you when you're going to hospital, well, not much use, but I would personally photocopy and take them, even if I was going for a small procedure. You never know. I wanted to know what your defence was of dying at home as opposed to in a hospice or hospital, aside from the family issues. What other thing would you think is good or bad to do one or the other?
Well, a number of studies have shown that 70% of Australians prefer to die at home, and yet 70% of Australians die in hospital. So we're clearly not meeting the need there. There's no reason if you are dying that you can't get good community palliative care, and I certainly know that Silver Chain are involved in providing excellent community palliative care here in WA. I think a lot of other states in Australia are somewhat envious of the excellent community palliative care delivered here. So can you just clarify apart from that, what were you asking?
If a person was on their own and they were having Silver Chain care, then someone may or may not be with them if they're in their home. They may die alone. as opposed to in hospital, they will be surrounded by people and getting the best care. You know, I suppose not being a medical person, I'm not convinced that maybe you do get the best care at home.
Look, I agree. Firstly, advanced care planning isn't saying we're going to make everyone die at home, because it's about actually finding out what the person wants. Secondly, I would expect a GP and the silver chain nursing or the community health centre, or indeed whoever in the hospital is looking after someone's condition, will help to guide them as to whether it's practical for them to be able to survive at home. Now, if they're living alone, they're not going to have anyone there who can help them go to the toilet or get them something to eat or drink or administer medication. So in those sort of cases, particularly if it's near the end, I would expect that they would be going to a hospice or some other sort of palliative care service, or they may need to go into hospital. Or they may have friends or family who can come and stay with them during that period of time. But obviously it's going to vary from case to case.
That's fabulous. Thanks very much.
And you also made the point about filling out the alert. Of course, we can always wear one of those medic alert bracelets saying not for resuscitation. Or you could even be like the elderly nurse who had it tattooed across her chest saying do not resuscitate, because she didn't trust the doctors to really listen to it. Hopefully by the time they expose her chest to start the cardiac massage, they then will stop, unless the tattoo's sort of aged over time and you can't read it anymore.
Any other questions for Bill?
Can I just ask those of you in the room, how many of you actually have done an advanced health directive? Okay. And now, having heard this talk, how many are interested in doing an advanced health directive? Yeah. I mean, I don't mind if you don't put your hand up, but I think that shows that you can see that there are benefits in it. And remember, just because you fill out one of these doesn't mean the doctors won't care anymore. It doesn't mean that if you turn up in hospital, they'll say, oh, they're not for resus, so we're not going to do anything. It's just about guiding them if you end up needing something and you've lost the capacity to be able to talk.